Welcome, everyone. I begin by respectfully acknowledging the Wurundjeri Woi-wurrung people of the Kulin Nation, who are the traditional owners of the land on which I stand and am hosting from today. In the spirit of reconciliation, NEA BPD Australia acknowledges the traditional custodians of country throughout Australia and their connections to land, sea, and community, and note that sovereignty was never ceded. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples attending today. Our organisation is committed to practicing allyship. Hello, my name is Belinda and I will be your host today. I work and volunteer for NEA BPD Australia in our office, and I am also a trained Family Connections leader. As you all may know, NEA BPD Australia is a not-for-profit organisation delivering programs, webinars and events to support families, carers and people in a relationship with someone who has BPD and or BPD traits, whether there is a formal diagnosis or not. Our main service is the Family Connections program, which is a free evidence-based 12-week program delivering psychoeducation, skills training and support for people who are caring for or in a relationship with someone who has BPD. Today, we are very grateful for a presentation from Louise McCutcheon. Dr. Louise McCutcheon is a clinical psychologist and joint founder of the award-winning evidence-based Helping Young People Early, otherwise known as HYPE, program, which is an early intervention program for BPD in young people at Orygen. She coordinated the HYPE clinical program for 12 years and has been an investigator on many of the research projects investigating treatments for young people and support programs for their family members and friends. Thank you, Louise, for making time for us and our audience. Welcome.
Yeah, you're very welcome too. Lovely to see everyone's faces. That's really nice. So much nicer than a webinar where you can't see everyone. Are you ready for me to share my screen?
Yes, please go ahead.
Okay. Hope this is the right one. Just give me a thumbs up if that's the right version. You can see it okay, good. All right. So maybe it's useful to start with just a little introduction for people who maybe don't know who Orygen is or what Orygen is. We're Australia's leading youth-focused mental health organisation. At the moment, we comprise a number of different kinds of clinical programs. So we have a specialist clinical program that has different streams of care. That's a publicly funded youth mental health service. And mostly what I'm going to talk about is, or anything that I'm referring to really is the research that we have is conducted in that program. And my personal clinical experience is mostly from working in that program as well. That's the program that we set up, the HYPE program. We also have 4 enhanced primary care or headspace services as part of the clinical programs. And we're moving to a different model, which will then also have a way of linking those up so that we'll have an intermediate service that's somewhere between primary care and tertiary care. So eventually we'll have even more kind of options of care for young people in our catchment area. We also have research and translation programs. So the research program we jointly work in. So I do research at the same time as I do clinical work, and I also work in the translation program or knowledge transfer program, which means that I talk a lot about personality disorder. I talk about the research and I talk about the clinical work. And the idea is that we try and integrate all of those 3 areas as best we can. Now, I know I've worked in other clinical settings where it's really, really difficult to get funding and time to not only do research, but also then to do training and other activities that share the knowledge. So I think we're pretty lucky to be able to integrate all of those things together. I know lots of people would like to be able to do more of that. So if I just focus on the public mental health part of the program, It's a service specifically for young people. At the moment, we see 15 to 25-year-olds. We're about to move down to 12 to 25-year-olds. We have a catchment area of 1.3 million in the north and the west of Melbourne. And primarily, we would call ourselves an outpatient service. And we do have an inpatient service when we also work with the Royal Children's Hospital inpatient service for the younger ones under 18. We have a hospital in the home program, which means they can go out and visit young people who are acutely unwell but can stay at home under the care of their family usually. We have a Y-Park, which is a recovery program that sees people for between 1 and 4 weeks, either a step up or a step down from the community or the inpatient unit. We have an intensive outreach capacity across all our programs, and we have an after-hours crisis team. And the outpatient program on all of our programs really try and focus streams of care on all severe mental health programs. So we have an early psychosis program. We have an early intervention program for personality disorder. We have an eating disorder program. We have a mood disorder program, neurodevelopmental disorders. So you can see there's streams of care. We also know that people don't fit nicely into little boxes. And often what happens is young people have an array of difficulties going on at once. And so that is sorted out through a sort of what's the most important thing going on for that young person that we need to address, and then they find their way into that part of the program. Sometimes people move around a little bit within that, but we try and minimize that. So that's the clinical program that I work in. As we said, it's called Helping Young People Early. So I want to just start. My intention in today's talk is to, I guess, give you an opportunity to hear what's the most up-to-date thinking across the field. Now, obviously, I'm just one person and I have one perspective, but I've been associated with personality disorder and working in this field now for probably about 25 years. I go to the international conferences, I hear what people are talking about, I read the literature. And so my idea is really to sort of synthesize that a little bit for you and to kind of give you a bit of a digested version of that so that you can hear what the thinking is across the field. There are obviously still some controversies and some areas of disagreement, as there would be in any area. And we can talk about that. If you have particular views or ideas, or you've heard specific things, I'm happy to tell you what my opinion is about that, or what I think that the research tells us about those things, so that you might understand them better. But my word isn't the last word and the only word. It's just one word. But I guess what I'm telling you is I'll do my best to try and summarize what I think are the issues. So one of the things that I think is really important across this field is that things have shifted and changed quite a lot in the last 3 decades, the last 30 years or so. And some of that has been the way we actually just even understand personality and personality disorder. So if we think what is a personality, we use that word very casually in our everyday conversation. We have an understanding that everybody has a group of characteristics that describes the kind of person that they are, so that describes both what makes us similar to some other people as well as different from others. And so that group of characteristics are what we can describe as personality disorder features or traits. And if we think about, what's important about those, really the most important thing is that it helps us to be able to live more successful lives, more productive lives, more satisfying lives. And when we think about, what a person is born into, it's an uncertain world. And things come and go and things happen to us. If we think about what we imagined our life would turn out like, of course, it's nothing actually like that. And that's so for everybody. So we know life is unpredictable. We know that things happen and things unfold in ways that we can't even imagine. And so our personality, when it's working well, supports us to manage that. It helps us to be flexible and adaptable to the lives the ups and downs. Think about the last couple of years, how everyone had to really change what they were doing and the way that they did everything as a result of that pandemic. It really showed up the people who were struggling to manage those, to be adaptable and to change, and the people who got more upset and distressed about those things. So I think if we think about personality being something that either supports us to be adaptable and flexible and manage life, or it gets in the way, that helps us to make that distinction between what's adaptive personality personality characteristics and what might be unhelpful characteristics of our personality. And I was just trying to think of some examples and thinking about, you know, somebody who's open and friendly is going to find it easier to negotiate getting through school and getting through university or their first job or whatever it is they do after school. Somebody who is, you know, really, really worried all the time, anxious and really stressed by the things that change, or by maybe the social burden of having to, you know, be scrutinized all the time, or is overly worried about anything really, then we can imagine that that person's journey through life is much more complicated and stressful and tricky and difficult. So if we're thinking about personality, we can be thinking about characteristics like how open someone is or how friendly someone is, and we would be all at different points along a spectrum. So that understanding has really led to a shift in how we think about personality disorder. So when things are not working well, it could be that they're working not well a little bit, and you might say this person has mild personality disorder, or it could be that actually the problems are really quite severe and there are lots of areas in which the person is not doing well or not managing the ups and downs of life. And then we would call that personality disorder more severe. So the categorical systems of naming a kind of personality disorder, you either have one or you don't have one, that's now considered pretty old-fashioned thinking. And we're moving to a way of trying to understand personality disorder as well as normal personality as being along a spectrum, and that we can be understanding that people do move around on that spectrum. They're not going to move dramatically probably through their lifetime. If you're struggling very much early on in life, then probably you're going to struggle throughout your life, but we would hope that you can struggle less as you get older or as you have treatment. So people are likely to be able to recognize that the people they love or that they themselves are somewhere along a spectrum. All of us will have some aspects of our personality that is less flexible or struggles with change a bit less. But hopefully it doesn't get in the way really significantly. If it's getting in the way really significantly, then we would be saying it's now something that we need to try and work on or intervene with. So I hope that makes sense. There are some caveats down the bottom here that, you know, you need to see this over a period of years. It's not just I'm having a bad month or I'm having a bad couple of months. What we understand in mental health is that people can have symptoms of a mental state disorder for a period of months, but then when it goes away, they go back to their usual self and they go back to coping in a usual way. Personality disorder is much more about the usual way that someone is managing. And we can see that it's not, it needs to be something that fits into the social group that we belong to and in our cultural expectations. And when it doesn't, then it's more likely to be called personality disorder. And we also need to make sure it's not caused by a substance or a medical condition or something like that. An example of that would be that when people get dementia, often their personality seems to change. The characteristics of who they are seem to change a bit. And so we would be calling that a symptom of the dementia, not necessarily personality disorder per se. The other thing that has shifted and changed with this new focus on dimensional views of personality and personality disorder is that we're now much more looking at how people relate to themselves and thinking about themselves. So whether their sense of identity is stable and coherent, they can make sense, they've got words to describe the kind of person that they are. Whether their sense of self-worth is stable and positive most of the time. Their accuracy of their view about their own characteristics, strengths, and limitations. If we have a really, serious disagreement with someone about how well they're functioning in the world, for example, then we would, and everyone around them disagrees with their particular view of that, then we would be thinking there's something going on for this person. Let's better understand it. And so it's our relationship with ourselves that we're interested in, and we're interested in their relationship with other people. How well do they get on? Can they engage and maintain relationships with other people? Are they able to understand other people's perspectives and point of view? Are they able to develop mutually satisfying relationships with other people? Do they get the social rules, that kind of thing? And can they manage conflict in relationships in an appropriate kind of way? So you can see that this really is also very culturally bound, these ideas. In some cultures, what looks normal and typical and, appropriate is not always going to be the same in a different cultural group. The other thing that I think is really important, and particularly important for where I work, is that we're also thinking about personality disorder as a developmental disorder. And what I mean by that is that we need to be thinking, what's typical for someone this age? What should we be able to expect of this person? And when they don't display that, or they're really struggling to think that way, then we're more able to say, well, this doesn't seem to be usual, and why might that be so? And let's understand it. I think that's particularly important also because people are on a developmental pathway, and in the age group that we work with, in the from 12 to 25 or the mid-20s, that's a very important period of life, that there are many, many things that happen. There's physical, biological sort of changes that go on through adolescence. There's social things that happen, the focus from family being the most important relationships to being focused more on peer relationships and how do I negotiate new intimate relationships. All sorts of things happen in the period between 12 and 25. So when people get, when that developmental pathway gets disrupted, it can really be quite significant for the person. And so one of the things that we focus a lot on in thinking about why we need to intervene early in personality disorder is that it can really significantly interrupt the developmental pathways for young people. We also look at things like emotions and how people think and reason. Is it rational? How do they, are they able to manage under stress, or do they deteriorate really significantly? How quickly? And how people behave. Are they able to stand back from what's going on and choose helpful coping strategies, or do they get pulled into, other things that might be self-defeating very quickly and easily? And can they get back on track if they feel that things are not going so well for them? Having said all of that, and before we get to, before I go on too much further, I want to say that most of the research in this area has been focused on borderline personality disorder. And I also want to say that the thinking nowadays is that the cluster of features that are associated with borderline personality disorder are very similar to what you would see if you looked at the people who have most severe personality disorder. And so the thinking at the moment is that those two terms are probably pretty much interchangeable. And one of the systems that we're using now, the ICD-11, that's the International Classification of Disease, which is put out by the World Health Organization, that invites people to actually not call it a particular kind of personality disorder, to just label the person has personality disorder, or just diagnose rather personality disorder, and then how severe is it. So the focus is very much now on severity. How much is the person's life being disrupted by the way that they usually are? And what can we do to assist them with that? And less focused on making a diagnosis of the kind of personality disorder. That's to do with the categorical system we used to have, and we're leaving that one behind. Now, both of the systems that we use most often are still allowing people to put in borderline personality disorder where that's appropriate. And that's a kind of intermediate step between having diagnoses of different kinds of personality disorder and moving to a personality disorder and how severe. Okay. So why do we want to detect personality disorder, and particularly early on in young people? So the first thing to say is it's really common in young people. It's the most likely time that anyone will have a personality disorder is in their adolescence or youth. Approximately 10% of the population will have a personality disorder. Approximately 3% will have severe personality disorder. And about a fifth of people attending tertiary youth mental health services will have severe personality disorder. By the age of 24, a fifth of young people will have had personality disorder and a fifth will have had severe. So it's common. It means that in most clinical settings, people are already working with personality disorder in young people, whether they make a diagnosis or not. And probably lots of people in this audience already will know of people where it's thought they might have a personality disorder, but it hasn't been diagnosed or it hasn't been told to the person. So it's a very common thing. The important bit about that is not really the label. We're not actually all that interested in the label. What we're interested in is the fact that this group of young people have really severe current problems. It's associated with high distress, and we've just talked about the nature of their relationships with themselves and their relationships with others, and they might be experiencing a whole range of extreme and inflexible kind of ways of managing that are very difficult for them. They have high levels of current mental health symptoms, and so we're talking about depression and anxiety and eating disorders and substance use difficulties. So a whole array of other mental health difficulties that are probably going on as well. This group of young people have poor physical, sexual, and reproductive health. They drop out from education, employment, and training. In our service, we did a study and found that 40% were not in education or were employed or were in training. They are at increased risk of being a victim or a perpetrator of interpersonal violence. So they get caught up in really difficult violent situations. They're more likely to be involved in non-violent offences and in family violence situations. They also have very low quality of life scores, and it's lower for this group than for any similar age disease group, including cancer. So these people are really not having a good time. And personality disorder is among the leading cause of disability right across the lifespan. It's important to underline that these difficulties that young people with personality disorder features are experiencing are not the norm. When we look at levels of impulsivity and substance use and sexual behaviour, when we look at self-harm and suicide attempts or interpersonal and vocational dysfunction, what we find is that the group of young people that have personality disorder features are much more likely to score on lots of those things. Whereas what is much more common to hear in the group that don't have personality disorder, who maybe go through a bad patch, they might experience some of these for a period of time, but they rarely have lots and lots, and they rarely have these persisting for years. So this group of young people are really doing poorly for years in these areas. And that's not normal. So that whole there was a very long-held belief that adolescence was a period of storm and stress. There's a German term actually that it came from. But really that's been pretty much debunked, that theory. Most young people navigate the period without a lot of difficulties. And although sometimes young people have conflict with their family members, rarely does it lead to, homelessness or people running away or really severe difficulties. Yes, it's difficult for a period of time, and it might even be a period of time that goes on for way longer than everyone wants, but it rarely ends up in a whole array of difficulties. And when it does, we would be really concerned. The other thing to say is that personality pathology does tend to settle down on its own. The natural course of personality disorder and personality pathology, so that means the disorder features, is that it peaks in adolescence and then it gradually kind of goes down over the lifespan. So by the middle 20s, most young people will have moved on from those difficulties and found more helpful ways of managing. Now, that we can't say that is going to happen for everybody. There's a small group who go on experiencing personality difficulties for much longer, and they persist well into adulthood. And they're the people that we're most worried about. However, one of the things that's very challenging is that it's really hard to know which people they are. Out of the large group that we see in adolescents who are struggling with these issues, it's very hard to tell which individuals are going to go on to have really severe difficulties into their adulthood. It's likely to be the people who are more severe that struggle more, but that's not across the board. And one of the arguments for intervening early is that helps us to find out who can get some early assistance and get onto a more healthy pathway and who continues to struggle. And I think when I talk with clinicians about this is what I'm talking about is the small group of people who go on to have the much more serious forms of personality disorder that are known to adult services, adult mental health services. And I think they're the ones who, unfortunately, clinicians hold in their mind as the typical person, when in fact the typical is the person who moves on. So that's a tricky thing. I want to address the question about, can we diagnose personality disorder in young people and what do we know about that? So there has been a lot of question about that, and early versions of some of the diagnostic manuals that we use and the guidelines that we use clearly said we shouldn't be doing it, or we should be cautious in doing it. That's shifted and changed over the last couple of decades. Given the amount of research that we've done, we can now clearly say that it's better to intervene early than it is to ignore the problem. And so the NICE guidelines, which are the National Institute of Clinical Excellence in the UK, the NHMRC, which is the National Health and Medical Research Council in Australia, they wrote up guidelines. We have the Diagnostic and Statistical Manual, which is one of the manuals that we use in Australia, and the ICD-11 is the World Health Organization one. And we also know that it's been translated into many of the guidelines in different countries. So in the Netherlands, for example, where I have quite a lot of clinical colleagues, their guidelines are very clear. And all of those guidelines say very clearly that we should make diagnoses of personality disorder when it's appropriate in a young person, and that there's no reason to hold off making a diagnosis until 18. In the old days, before we actually looked at what was going on in real life, we had ideas about how personality was very flexible when you were an adolescent, and suddenly, when you got to be an adult, whenever that transition suddenly miraculously happened, But when you were an adult, somehow it was defined and clear what your personality was going to be like. And what we know now is that actually personality changes across the whole lifespan. So that there isn't one point when we say, okay, now it's clear. And in fact, if the time that's most settled is around your 40s and 50s. And so we're not going to hold off at making a diagnosis before intervening until you're 40 or 50. That would be crazy. So we need to actually make a decision about what's going on and try and intervene when it's there. So that's the argument. It's clearly recorded in all of those things, and we have Australian guidelines that back that up as well. I did want to just stop for a moment and share with you a young person talking about their experience of diagnosis. It's not always straightforward, and people can do it well and they can do it poorly, just like a diagnosis of anything or just like information about anything. So I think that this is an important thing for everybody to think about. And I think it has coloured how we approach the whole concern about, making a diagnosis and the effect of that on young people. So I'll just play you this.
Okay, so the first time that I was diagnosed, I had gone in to see a new psychiatrist, and I was in an interesting state of mind, very ready to end my life. And I went in there I need help right now. And he came back at me with, I think you might have borderline personality disorder. And I swore at him and I stormed out of that appointment like, what an idiot, he doesn't know anything about me. And I was furious and so many emotions. And then I got that diagnosis again when I came to a specialist youth mental health service, and I was explained, it was the first time that someone had explained to me what that illness was and how it had presented in my particular behaviours. And then it was a realisation of, oh yeah, you're right, definitely. And that diagnosis done that way with proper education was life-changing for me. I finally understood myself and why I was the way that I was and why I had caused so much damage, and I could finally recognise my troubles and do something to address it and make myself a better person, which has really helped. I like being me now. Okay,
so I guess, the important part of that is that it's our own stigmatizing ideas that get in the way of us talking about personality disorder. We're not very good about it, being open and being honest about it. I don't think we're very good at being clear and kind of being practical and no nonsense. For some reason, we have a lot of concerns about damaging people, which are legitimate concerns, but they get in the way and make it into something that is actually unhelpful. So I think my view is that we should be treating it like any other problem. I don't have a problem describing depression to somebody, and if I think that they're depressed, I would share my concerns. I'm worried that you might be depressed. Can we talk about this? Can we unpick this? Can we find a way to support you? And that's the way I present personality disorder. It feels to me like things have got really stuck for you and that you're engaging in things that are actually getting in the way of you living the life you want to live. How can I help you find better ways of managing? Most people can get better outcomes if we can sit down and work together. And so I can share that optimism that I think we can make things better for people, not fix everything entirely, not fix everything perfectly, but definitely work towards having things be more manageable. And so I think that the stigma is really something often in clinical settings. Often it's clinicians who are stigmatizing people the most, but we really need to do something about that. That's kind of my impassioned plea that we need to attack stigma and really try and deal with it. And I think it is manageable to deal with. So I do also want to acknowledge that it's not just the young person who can struggle and have difficulties, that actually the people who care for those who are living with personality disorder, and particularly BPD, also struggle. We know from lots of research now that they have greater negative experiences of care. Care is hard. They have fewer positive experiences. They don't have so many times when it feels like it's all going well for them. There are higher levels of expressed emotion, and that's a particular term used to describe the kind of high levels of conflict in families that sometimes happens. They often have experiences that are worse than those for caregivers of other young people with either first episode psychosis or anorexia nervosa. So we've compared the families of the people that come through the HYPE program with some of the other families that come and support young people coming to the service. They have high levels of burden, anxiety, depression, and grief. And carers of young people experience elevated levels of distress. We also know that they can struggle with their own mental health difficulties. So 58 or almost 59% reported a current mental disorder, and 69% described a mental disorder in the past 12 months. So that's depression or anxiety most commonly. But, you know, when it gets to the point that it can be diagnosable, then it's fairly extreme and people are really suffering. The other thing to say is that young people with personality disorder are also more likely to have difficulties in their relationships with their family members. And that means that they've often chosen to disengage or had to disengage from their families. So we have a much higher rate of young people not living with their families anymore by the time they get to the age of 18. And there may be lots of different reasons for that, but that does mean that it is difficult for the family, and it's also difficult for the young person. Having said that, though, we know from our experience that young people want their relationships with their families, even if they're not living with them, to be better. And family members often worry and would like their relationships with their young people to be better as well. So even in situations where they're no longer living together, we feel like the connection between young people and the families and the friends and the people that support them are really important relationships and things that we should be able to support and to help to function better. We know that when we do assist the system around the young person, that helps the young person to engage better in the treatment that we offer, and that it's very rarely unhelpful to do that, even though we commonly hear from young people, especially early on, oh, I don't really want you to contact my family. That's a reasonably common thing for young people to say. What we do is usually try and negotiate that we'll come back to that and try and find a time when it will work better for the young person to include their family. We acknowledge that families like to be included wherever they can. And so we work on that as much as we can. The needs of young people, of the families and friends of young people with personality disorder, there has been not a huge amount of research specifically on the families of young people, but what we do know is that families often report that they don't know as much as they would like to about personality disorder, and they would like to know more. They worry about how to respond to challenges and particularly high-risk sort of behaviour. And we also know that having a limited understanding of personality disorder can also contribute to making things worse in some ways, so that it's more likely that people will respond quickly without understanding the nuances of what might be helpful ways to respond. They might feel personally attacked and therefore, want to lash out at the young person when they feel hurt, for example, rather than being able to understand a more helpful way of managing. Having said that, we also acknowledge how stressful and tricky it is to live in a difficult situation 24/7. That's not what clinicians have to deal with. they have to deal with something completely different from that. So families are carrying the sort of long-term understanding of what's going on. So we can be thinking about communication styles and responses that are helpful, responses that manage risk and things like that with families. And sometimes families, as I've already said, have their own difficulties. We know that BPD is a complex problem and it doesn't just come out of nowhere. People are doing their best. And so we want to not blame people, but try and understand what the developmental process that a young person's going through and how to support that best. So personality disorder acts as a gateway to serious problems in life. And I'm probably noticing that we should probably speed up. I'm going a bit slow maybe. So I'm not going to read out all of those problems, but you can see they're an extension of all the problems that are going on currently for young people. And those problems can persist for really quite long periods of time. What that means is people may not have a diagnosis of personality disorder for decades, but they can experience difficulty finding their way with education and vocational pathways, for example, for sometimes very long periods. Some of the most important difficulties that can translate, though, for this group is that life expectancy can be reduced by up to 2 decades, that they have a 10% suicide rate, which is high. That's around the same as for young people who have psychotic disorder or schizophrenia. So it's something significant and it's way higher than we would like it to be. So what are we trying to change? One of the things that we want to focus with early intervention is that late intervention is actually the routine way of dealing with things in personality disorder across the world, I would say. We put off making a diagnosis until people have had problems for years. We only offer specialised treatment. We don't offer a whole array of simple through to specialised treatments. We offer them late in the course of the disorder. That means when there's specialised treatment, it also means that sometimes that means only a very small number of people can actually access it. And it means that people have entrenched disability rather than early in the process of that. Our service systems are also poorly organised, which means that most people don't get available evidence-based treatments. It's kind of haphazard access. It depends on where you live. You might be lucky and there might be a personality disorder service near you, or you might be unlucky and not have one for kilometres and kilometres. There's not much coordination between service systems. There's almost always an exclusive focus on transactional presentations around hospital and emergency. And really what we're talking about is that people get into crisis asking for care. This is the only way that they can communicate they need care. They go to the emergency department or to hospital for a little while and really they don't get what they need. So then they go out and then the next time things don't work for them, that's the only pathway they know. And so it's a bit like a revolving door. They go in and out and in and out and they're not getting their needs met. The other thing is that most personality disorder programs focus on individual therapy as the only form of treatment, and we see that quite a lot, that they don't offer assistance for substance use or problems, or they don't help people into a vocational pathway. They just offer therapy and people have to go somewhere else for all of their other needs, even though we would argue that they're associated with their personality disorder. And a private system is often not very suited for people with personality disorder. We've talked about the high rates of unemployment. So these people are not normally able to purchase for, private treatment. The other thing is that service systems are hostile to the people themselves as well as their families. So often people experience being turned away. They've experienced bigotry and discrimination. We expect patients to fit in with what we want them to do. So we expect them to adapt to our waiting lists and things like that, rather than being more adaptable and fitting our treatments to what young people or their families need. Families and partners often feel marginalised or blamed. And we can do damage to people. We can end up hurting people through our service systems that aren't well constructed. We teach people to engage in high-risk behaviour to get our attention or to get service, and that's not what we should be doing. So we're trying to turn that around by talking about early intervention. We're trying to think about how to address the delays in treatment, how to manage underdiagnosis or ineffective treatment, or inappropriate or harmful treatment, or alternatively overdiagnosis. We don't want to do that either. And we know from various studies that in the Headspace setting, which is youth mental health and the primary care area, that the rate of diagnosis of personality disorder is at least 1/10 of what we would expect. So we know, even in that setting of youth mental health, that it doesn't get diagnosed in a way that actually reflects the prevalence in the community. I'm just going to skip over that because I need to move on. So early intervention for personality disorder represents a shift in the culture of youth mental health. We have enough science and enough research to be able to say that this is worth doing and that it's supported by evidence. But we know that the biggest barriers are stigma and bigotry. And although clinicians and others who argue against diagnosis are well-intentioned and want to protect young people from bad experiences, what they're also doing inadvertently is preventing them from accessing treatment. And so we argue that we should be making a diagnosis in young people. I know that's a controversial thing to say for many people. If we quickly look at the effective treatments and what do we know, there are now 9 published randomized controlled trials of structured psychological intervention in young people. That's a long way from where it was 10 years ago. In most trials, structured psychological interventions were superior to the treatment as usual regarding the rate and the amount of improvement on the primary outcome. But having said that, the differences between the two groups are, like all of the evidence for personality disorder treatment, they're clinically modest. That means they're about as effective. They're not effective for everyone, and they're about as effective as taking an antidepressant for depression. It doesn't work for everyone, but it's worth trying, and we have some evidence that it's useful for a number of people, and it's a big enough number that we should be doing it with everyone. The treatment evidence also supports that we offer treatments matched to the clinical stage. That means we offer shorter, briefer, more benign kinds of treatments to the milder people, and we save the more intensive treatments for the people who are more severely unwell, rather than offering everyone severe treatment for severe personality disorder and then not being able to offer it to very many of them. Clinical staging is a way of trying to match the intensity of the intervention to the stage of illness. And I've got a sort of picture of that. I'm just going to quickly click through that study because I want to also talk about the staging in a way that's helpful for everyone. So rather than ask what's the
Is it me that's frozen, or I think Louise, you've frozen. Sorry, everybody. Apologies, everyone. It looks like we've lost Louise. I'll just try and see if I can contact her, and we'll see her log back in just a second. Play some hold music, perhaps, and we'll see what we can do about getting her back. She's on her way back. Please feel free to grab a glass of water or do whatever you need to do for a quick minute, and we'll restart again.
Yes. Can you hear me now?
Yes, wonderful. Welcome back.
Okay, I'm really
Not only
sorry
did we
about that.
lose you, but I trapped you and you couldn't talk to anyone.
Yeah, I was waving, but that wasn't,
No,
I wasn't
I
catching your
couldn't see
attention.
anything. All right. Thank
So-
you. Welcome back.
I'm very sorry, but I have to join from my phone, which means that I can't show you my slides anymore. So I think the main message probably everybody has well and truly heard, that we need to be able to promote early intervention, and that hopefully it's really not rocket science. It's pretty basic and simple, and all clinicians ought to be able to provide some version of that from wherever they work. And I guess families and carers should feel empowered to talk about that with clinicians, to talk about the value of early intervention. If they feel like their young person is not receiving that, then they should be. And maybe we can just go to questions.
Louise, have you lost access to your computer as well? Would you like me
No,
to
I can
read out the question? Okay.
I can see the list.
Yes.
I guess the question would be, how have I answered all of those questions? Because I've tried to answer them as we go. And
Mhm.
maybe what we could do is see whether people have anything else.
Okay, so we've opened up the chat now. So if you have got some questions,
Okay.
please pop them in. If you did ask a pre-submitted question and we haven't answered it, feel free to pop it in the chat now.
So the one question which I didn't answer, which I'll do just while we're collecting some other questions, was what is 20 or 21 too old for early intervention? And I would say absolutely not. Our program works with 12 to 25-year-olds, and mostly what we're referring to by early intervention is the stage of disorder. If people have had years and years and years of other treatments, then perhaps we wouldn't call that early intervention. Usually the people we expect to see are people who are receiving that diagnosis for the first time. That doesn't mean they can't already come in with that diagnosis, but they probably haven't had much treatment. We do see young people for early intervention, and we also provide care in that age range, no matter what is going on for that young person. Yeah. So you might have to read those questions out, or some of them.
I'm happy to do that. Bev has got her hand up. We're not necessarily going to be taking some live questions, Bev, but Bev is one of our Family Connections leaders.
Yeah.
Let's just, can you, yep.
I actually put it in, thanks Belinda, I put it in the chat. I just wanted to say thanks, Louise, for this, but also could you got cut off when you were talking about staged clinical interventions, and I wondered what the difference is.
Oh yeah, okay.
What is your intervention? What is the difference between what you might consider, what you might do for someone who had mild symptoms rather than severe symptoms? Like what does that look like?
Yeah, that's a great question to ask. So the difference between, say, stepped care, which is where basically everybody gets offered the first step, and if you don't get better, then you get offered the second and the third. The idea behind that is, or the concern that I have with that is that you basically have to fail the simple treatment before you get access to the more complex intensive treatment. So staged care is about choosing the best treatment to fit the young person's level of severity now. So if they're really not managing well and there are many problems going on, then I think that what we would want to do is say, actually, your things are very complex for you. You need a more intensive treatment right now. And we might have a whole multidisciplinary team that has psychiatrists in there. And we might be thinking about some medication might help your co-occurring problems, for example, or we might need some other psychosocial treatments that are going alongside whatever the clinical team is doing. So there might be multiple arms of that treatment, and we might expect to see you more than once a week, for example. Whereas somebody who's earlier on in the whole pathway of that disorder, who hasn't got such complex things going on, who may be experiencing a few features of personality disorder, might be able to have much more simpler treatment delivered by people who don't work in a tertiary mental health service. It could be a private practitioner, it could be someone from Headspace, it could be a peer worker. You know, that might be enough for that person to feel like they get some care, they get some help with their current difficulties and can kind of get back on track. I think with everyone, we want to aim for episodic care. So giving people episodes of care and then giving people a bit of a break. The idea that you want to take people in at 12 and then keep them for decades, I think is not helpful, because we all know that it's possible for people to get institutionalized where they don't really learn stuff anymore. They don't learn how to interact with their peers and with, learn how to get a job and learn how to live a life that is meaningful and interactive and satisfying. So we want to give young people as many chances to practice the skills we teach them. So mostly we want to give people an episode, a short episode of care, and then say, we're confident you should go out and try this. And if things really deteriorate again, come back. And so it should be an open door for people to come back when things don't work, because one of the things that we know from young people's experience is they're probably going to dip in and out of care anyway. And what we want to do is have a really positive message for when they are trying things out, rather than a sort of expectation like you're going to need, mental health care forever. I think that's such a disabling kind of message that we give people. You're really complex and you need care forever. You'll never be able to live a life. And that's just not true. So we don't want to be saying that to people. And I think it's a subtle message we have to be able to get right. We're hearing what you're saying. We're taking your concerns seriously. Let's give you some care, but also let's not overdo it, because that won't be helpful for you. Yeah. And I think it is about working with the individual person to get the message right for them as well. What's going to make sense for this person. It's like the young person in the video. When things were talked about from their point of view and really explained in a way that made sense to them about their difficulties, then it was like, oh yeah, you're right. And I think we often feel like we have to say this generic thing to people, and it's fair enough, we do have to say some things that are generic, but I think it's also about individualizing the message, and that makes it much more meaningful.
That comes on to, I guess, that the people are asking, because your slide froze on what is the best psychotherapy for PD?
Oh, I think it was not, we shouldn't ask that question. We should say, yes, what is the best solution for meeting the need at the frequency that it is in the community? And often we get pulled into which is the best psychotherapy. Actually, we don't even know if psychotherapy is necessary for treatment. In fact, there are new studies that have just been published in the last little while that suggest that that's not the thing that is making the difference, that actually having a structured response to people that's not stigmatizing, that's welcoming, that's, encouraging people to take ownership of their difficulties and, approaches the challenges in a really straightforward, honest, open way, genuine way, and says, I want to work with you. I want to help you, find the best way for you. That's much more meaningful than a psychotherapy. Now, we don't know for sure. There's only a few studies that have started to look at that, but good sound treatments, and this is across the board in adults as well as in young people, good sound treatments that don't have psychotherapy as a core component are getting good results as well. And that just means we can offer those kind of treatments to many more people. Psychotherapy takes a long time to train in, and it's expensive. And so we want to keep that for the people that want and need that.
We've got some other questions about links between BPD and other neurodiversities.
Oh, that's a great question. Yeah.
Autism. Yep.
I think that's a bit of a cutting edge area in the field. I don't think we have any really good answers. What I would say is that the rates of neurodiverse kind of diagnoses like autism spectrum disorder or ADHD and things like that are probably higher in our group of young people. And I'd say there's probably more overlap. There's also more overlap in sexual diversity and gender diversity as well. Now, I don't think I don't know what that all means, except to say that those kind of difficulties are more trait-like anyway. They're more enduring, persistent kind of ways that the person sees themselves in life, or ways that the person understands themselves, relates to themselves and relates to others. So it makes sense from that point of view. I think we still have quite a lot of research to do around teasing out some of that. And I look forward to actually understanding it better, because I think that it's a really good area to be thinking about. It's also fair to say that some of these issues depend on, how willing we are to make diagnoses and not. The rate of ASD, for example, autism spectrum disorder, it's diagnosed more in Victoria than it is in any other state of Australia, and ADHD is diagnosed more as well. Does that mean the actual rate is higher? It's a little bit hard to say, but we are a little bit more open-minded about diagnosing it. Is that a good thing or not? Then there'll be a whole lot of perspectives about that. So I think it's still an area we're trying to make sense of and understand.
Possibly another area is people are asking about with similar complexity is when people with PD or severe PD are also experiencing substance use disorders.
Yes, so that is something worth talking about as well. I think it's a little bit of a chicken and egg thing, which comes first, and I think that's the job to tease out. Did the personality difficulties sort of predate? Is that why people are using substances? I think that if people who are engaging in a lot of very heavy substance use can look like their life is pretty up and down and chaotic and very, very difficult, and that can look like personality disorder. When you go back and look at the history, though, we might say actually those difficulties were not there until that person was using substances very heavily. So sometimes heavy substance use can look like personality disorder, and then the vice versa is also true. I wonder if there's some questions about PTSD and complex PTSD, because that often comes up as a question as well.
Yes, they are. There are.
So what I would say about that is that the tricky bit about relabeling borderline personality disorder as complex PTSD is that they're not exactly the same thing. It's true to say that many people with personality disorder and complex or severe personality disorder have experienced trauma, but not everybody. And in our cohort of young people, there are almost 30% that don't report having had experiences of trauma. So the problem really with relabeling BPD as complex PTSD is that we would be ignoring the needs of almost 30% of the group, that it doesn't explain that group in that pathway to end up with the same difficulties. The other thing is that there are symptoms that go along with complex PTSD, such as re-experiencing difficult situations, re-experiencing episodes of trauma. There are many people with personality disorder who may have had traumatic experiences long ago, but are not experiencing PTSD right now. And so they also don't really fit into the complex PTSD label. So it's a tricky area. I think most people who argue very strongly for calling it complex PTSD are doing it for good reasons. They are worried about the label, they are worried about the stigma. The problem is that it doesn't apply to everybody, and so that actually makes it really difficult. And I don't think if we had a better name than borderline personality disorder, it would have been changed long ago. It's a complex thing, and we haven't found a better way.
We have lots of questions from people in other states other than Victoria asking for services, early intervention services, and also in Melbourne and not in the catchment of the Northwestern.
Yeah. So I think that's a challenge. There is a call in the area of psychiatry to make youth mental health a specific area of specialisation. That hasn't been done until now. And there are calls from different people to roll out early intervention. We provide training to people all around Australia. We've trained people in headspaces and other sorts of services like that to be able to understand what the model is of simple, sound structured treatment. We call it relational clinical care. But what's missing is the structures that kind of support that. And so at the moment, even if you go to a headspace, what you might find is that the treatment is very variable. And unfortunately, as I showed from the recent study, it's being diagnosed even in headspace at a much lower rate than we would expect to see from the known frequency in the community. So there's quite a long way to go. I think what I would say is people need to argue loudly and advocate for young people to get access to early intervention. There's lots of literature supporting it, but we all know that clinical services take up to 17 years to change what they do on the basis of research. It's like turning around the Titanic, unfortunately. And the best way to manage that is to argue loudly. Parents and carers are the most vocal group of people and the most likely group that politicians, for example, will listen to. So I would be using NEA BPD and other carer forums to advocate loudly for early intervention.
We've had a lot of themed questions as well around families feeling separate from the treatment that their young person is receiving, and whether that's due to estrangement or confidentiality. How do they manage those spaces?
Yeah, that's a good question. As I said, that it's not uncommon for young people to say they don't want their family involved early on, and some of that is an understandable response to the kind of developmental stage that they're at, that they're trying to be autonomous and make decisions for themselves. The difficulty is that we think it would be mostly beneficial for families to be involved. So we always talk to young people about the value of having their family involved, or their carers. Family is a very loose term. We use that very broadly. It could be their friends. It could be whoever is sharing a house with. So we take a line that's a really helpful thing to do, and we try and engage young people to think about that. It does mean that sometimes we have to kind of agree to put it on the back burner and then come back to it. I think if you're a family member and you're concerned, especially if the clinical team has said that they will let you know or they will include you, and you don't feel like you're being included enough, I would make time, request some time to talk about that with the case manager, with the clinician. I think there are different perspectives about what's a reasonable amount of engagement, and maybe the clinician thinks they're doing a good enough job and you feel like you're not being heard enough or contacted enough. So I think it would be perfectly reasonable to say, can we talk about what's reasonable? What do you think is reasonable? What do I think is reasonable? What does the young person want? So that you invite the clinician to really think about it and engage you. Sometimes family members worry about being seen as demanding. And I think, like any person in this day and age, clinicians are busy. So it's true that if you just end up, haranguing them, that you might be seen as demanding. The best way to do it is to try and collaborate with the clinician, to tell them what your experience is and what you think will be helpful and what you'd like from them, and invite them to be part of a discussion. And that's what they should be doing with you.
Okay, I'll keep looking through some of the questions. Just quickly though, a lot of people are talking in the chat about Family Connections and our 12-week program. I
Yep.
will provide a link to how to register and a bit more information we can send out to you all about how to access that program. That we do deliver that nationally. We are a small team of volunteers, so there are limited programs, but yeah, I'll send all that information through in a minute.
Yeah. So what we didn't get to talk about is the sort of evaluations. There's just been a systematic review come out recently of interventions for families and carers. And, you know, I think the important thing to say, just like different treatment modes, there's not a lot of difference between the different treatments. So the different groups that you have available, there's probably not going to be a major difference between them. Like I would say that most of the interventions for families are worth doing, are valuable, and different clinicians will offer different ones depending on where their strengths lie. If you don't have access near you, then I would also say there are online things that you could also engage in. There are online support groups, and there are other things that you can do to educate yourself or find out more. And there are also other forms of support that you can get that might be a bit more individual if you're living, you know, in a remote area, but still worthwhile.
I think Louise, you did refer to this. That is one of the issues that HYPE is trying to address, and is that traditionally, this is a lot of conversation in the chat, that many families have experienced that their young person with BPD has been deemed too extreme to treat. What would your advice be?
That just seems like such a crazy thing to say, doesn't it? You're too extreme and needy that we can't help you. I'm really sorry to hear that. I think that what that means is that the tertiary services need to be able to help that person. It sounds like the decisions being made that they don't fit into primary care. And what we do know is that a lot of young people fall in the gap between primary care and tertiary care, especially if they're over the age of 18. They often feel like there aren't services. What I would go back to is that there's good evidence that even generalist clinicians can help people with personality disorder. The more severe and chaotic their behaviours, the more stressful that might be for individual practitioners. And when people are engaging in a lot of risky behaviour, that is a tricky thing to manage in private practice. But it's not that people can't do it. It's more that clinicians need supports. I would be going back to the tertiary services and saying, well, where can my son, daughter, young person get some assistance if the primary care say they're not able to manage. I think, unfortunately, what often happens is that the message is given, you're too extreme for primary care, but not sick enough for tertiary care. And that means we have to all just wait while things get worse. And that's such a terrible, terrible thing to be living with. And unfortunately, I think it is the way that the system is set up at the moment. That's why our systems are not fit for purpose. But we need to lobby the politicians, we need to lobby the health departments, we need to lobby the services that are around, and we need to keep on saying, actually, this is a doable problem. It's not as complicated as it needs to be. There are things we can do. And even peer workers are helpful for young people who have personality disorder. So you don't have to be a mental health clinician necessarily.
Yes, okay. Someone has summarized something there. I think the question people are asking is, where do we get the best care for our children? you've presented the latest research and current information tonight.
Yeah. Well, I'm not sure that there is one answer to that, because I think that different people will need different things. And it's also going to end up being what is around you, what can you access. I think the hopeful part of that is that actually we have over 20 different kinds of treatment developed specifically for personality disorder. And all of those things have been shown to have good outcomes. Now, they're not always exactly the same outcome, and they don't all work for every person, but that's a really hopeful thing, meaning that whatever's around you that's designed for personality disorder is worth trying. There's good things from all of those different kinds of treatment.
There's lots of great chats in here. I'm just trying to. Okay, this is also a theme, is how do we get our young person to take ownership of challenges so that they can address if they take no accountability for their actions. And I did notice a lot of questions in the pre-submitted questions similar to this. How do we encourage a young person who is resistant to accessing support for their challenges?
Yeah, that is a good question. One of the things I would say is don't give up hope about that. I wonder whether when people are defensive and they feel blamed, then they don't really want to go and get treatment because they're feeling like that they are somehow causing the problem, or everybody thinks they're doing it on purpose, or something like that. So they feel blamed and they feel judged. If we can help people understand that we're not trying to blame them, that we're trying to understand and help them have be able to move towards their goals a little bit more effectively. I think that that's probably the best way to help young people engage in treatment. I'm not sure that families are always the best person to be having that conversation, though, because I think, the young person is expecting you to kind of get cross with them or to tell them they're not doing it properly, and whether or not you are actually doing those things, that's what young people kind of expect of us as parents. Yeah, so it's sometimes tricky for parents to be having that conversation. In a way, it might be easier to find someone else who can have those kind of conversations with a young person. When I sit down with a young person and say, so what is it that you would like to be doing if things were working out a bit better and you weren't feeling as stuck as you are now, or as hopeless as you are now? What would you like to be doing with your life? Where would you like to get to? And so we try and together look kind of ahead a bit, look down the track a bit. And of course, that's not an easy thing for a young person to do. Most of them can't think about tomorrow, let alone 5 years down the track. But if we can help them to look ahead a bit more and to start to imagine, what could I be doing, or what would I like to be doing if things were a bit more settled, then we've got a bit more shared way forward. We've got a bit more kind of leverage to help us both stick with things when they're not working so well. I don't know if that's helpful.
I think it definitely is. And one of the things that we teach in the Family Connections program that we've got, it's about the dialectics involved in conversations, and about changing the way that we use language when we're talking to the person who's experiencing dysregulation. And yes, if any of you have not done Family Connections, I highly, highly encourage you to sign up to do a program.
Yeah, I think any tools that we can get that help us be a little bit more deliberate and measured in how we respond and how we communicate is always useful, because family relationships when we're really worried about someone can get very heated and stressful. And it's very easy then to react a little bit too quickly. And that's not what we're intending to do, and we're trying to be measured and all of those things, but it's hard to maintain that when things are stressful and when you're really worried about someone. The other thing I would say to parents and families is there isn't just one bite at the cherry, there are many bites at this cherry. If people are likely to have ongoing problems for periods of time, then I would say back off, leave it for a little bit and come back to it if it's not working. Look for other moments when you might be able to introduce the idea or suggest they find out a bit more about, the programs on offer or different services. There might be a moment when the young person says, actually, I would like to manage this particular difficulty better. And then that's the best time. So it doesn't have to be, that the first time you offer help, if they don't engage in something, it's all downhill or their life is over. That's not true at all. Many people drop out of our care and then come back at some later time when it's better for them. So I wouldn't give up the hope, but I'd try and be there in the background thinking, when am I going to find a moment that it might be a better time?
All right. Well, I think that we have come up to time. This has been an absolutely fantastic presentation. Thank you so much, Louise.
You're welcome.
I've learned a great deal tonight, as I'm sure most of our audience would have. I'm sure we'll get a lot of questions. Would you be able to provide the slides?
Certainly. Yeah.
Fantastic. Well, I will send those out in the next fortnight when we get the recording of this sorted out. Now, I hope if everyone has enjoyed today's presentation. And yes, thank you once again to Louise. Thank you to our audience for your support, for your donations that you have made. I've popped a link in the chat about Family Connections and how to register. There's also a flyer there. And I'll just pop in here our email address if you'd like, if you've got any further questions about Family Connections. Also, if anything, you need some more information about early intervention or programs, we can try and find out some more links and resources to send through to everyone.
Yeah, and Belinda, I'm happy to come back and talk more about relational clinical care and the skills that we think are useful for all clinicians, if that's a topic that people are interested in.
Yes, I can see lots of nodding heads on the screen. So I'm sure that would be absolutely fantastic. And
the other thing is to promote is the lived experience of caring day at the International Society for the Study of Personality Disorder conference that's in November.
In Sydney. Yes, definitely. So we will be sending out some information on getting tickets for that day. So that's open to all families, and it's a one-day program that is very accessible financially. And yeah, we're a partner at the conference, so we'll be sending out some information for our families very soon. I think they've got limited places, but it sounds like it's going to be a fantastic day. I wish that I lived in Sydney so I could also attend.
Yeah, great.
Okay,
Thanks
wonderful.
Everybody for
Thank
all
you,
your
everybody.
questions. Yeah, really good. Okay.
Bye.
Bye-bye.